I think Avatar over the last 8 or 9 years has grown into the premium institute for making the endovascular outcomes and AV fistula outcomes in patients with CKD, patients with end-stage renal disease better. A platform like Avatar is what we need to highlight the high mortality and the high morbidity that our patients face. Our patients have to undergo dialysis twice a week, 3 times a week, and their lifeline depends on having a patent, functional AV fistula. And when the AV fistula fails, they end up returning back to the hospital. They have to spend time in the hospital. They end up getting what we call a catheter, which is a tube in the neck to do dialysis. And a catheter has a very high risk of infection. If you leave the catheter in a patient, you will get an infection every 4 to 6 months. And the chances that you will die from that infection is very, very high. So I think having a platform so that we can try and discuss, share, come up with ways to improve AV fistula outcomes is vital to improving the care of ESRD patients anyway. So fistula can be done in various locations. A fistula is basically a communication between an artery and a vein. The most common site to do a fistula is in the forearm or in the upper arm, mainly because when you are on dialysis and you have a needle that the fistula is being accessed by in the forearm or upper arm, say on the left side or right side, it's the easiest and the most comfortable place to be in. The second most common location for a fistula is in the thigh, where the needles are placed on the upper thigh at the time of dialysis, which is also convenient, but it's not the best comfortable shape to be in for 3 to 4 hours with needles in the thigh and the thigh exposed during dialysis. Very rarely some of the surgeons would do fistulas in the upper neck. It's called a necklace fistula or a necklace graft. It's vital that nephrologists and all medicine physicians recognize that patients who may be at risk of developing dialysis in the future do have a plan to preserve the veins while the patients are still in the early stages of chronic kidney disease, so that in future when they do need a fistula, those veins are preserved and they are able enough to develop into a fistula when needed. A fistula, a functional fistula, has to have a full circuit. The blood starts from the heart and has to go back to the heart. If there is any blockage, any constriction, any kind of stricture in the path of that inflow, all the way from the heart to the anastomosis in the upper arm or the lower arm, or in the outflow vein, it will decrease the flow in the fistula, it may increase the pressures in the fistula. The patients should be encouraged to feel their fistulas regularly, and if they find that there is any stenosis, or the staff finds that there is any problem in that access, then those patients should be referred timely to get probably an ultrasound done, and perhaps if indicated, an endovascular intervention to improve that problem and take away that stenosis.